Good afternoon, everyone. It's my pleasure to welcome you all to today's event, which is called Take the Right Path this December, Advancing HIV and AIDS Awareness and Research. As you know, 1st of December is the World AIDS Day, a day that unites people across the globe to raise awareness about HIV and AIDS and demonstrate international solidarity against this ongoing pandemic. It is my honor today to introduce to you Dr. Robert Ridley. Dr. Robert Ridley, I can see you now. Yes, I would like to introduce you to the panel, Vice Chancellor of the Unicaf University in Malawi. Welcome, Dr. Ridley. We are also privileged to have with us Dr. Lamek Wewa, who is the Deputy Vice Chancellor of Academic Affairs at Unicaf University in Zambia, and who is attending today on behalf of Dr. Christine Mushimbwe, Vice Chancellor of Unicaf University in Zambia. And I would like to give the floor to you to introduce all the members of the panel today and our presenters. And thank you all for being here, and we look forward for a productive and insightful event. The floor is yours.
Okay, no, thank you very much, and welcome everybody to this event where we're able to celebrate World AIDS Day, albeit a little bit belatedly, and have a discussion around the issues of the topic of this year's World AIDS Day, and at the same time just highlight some of the research and activities that we at Unicaf are doing in the field of health research, and particularly as it relates to HIV and AIDS. We're delighted to have with us today both representatives from Unicaf University in Malawi and Zambia, and in particular to have representatives of major HIV and AIDS organizations in Malawi and Zambia. From Malawi, we have apologies from Dr. Beatrice Matenji, who's the CEO of the National AIDS Commission. She was unavoidably asked to attend another important meeting, but we're delighted to have in her place Emily Kayimba, who is the Executive Director of the Malawi Network of AIDS Organizations in Malawi, and she will have a few words to say by way of introduction later on. And also from Zambia, Kebi Musukutwani, who's the DG of the National AIDS Council in Zambia. Very warm welcome to you both, and we look very much forward to hearing your very practical knowledge and experience of the challenges of dealing with HIV and AIDS in Malawi and Zambia. Later, after the introduction by Emily Kayimba and Kebi Musukutwani, we'll have a main presentation, and that will be introduced by Dr. Chela. And later, after the main presentation, we'll have two of our doctoral students present, and they'll be introduced by Dr. Wilfred Maceo. I think that's all I need to say by way of welcome and introduction. Just to mention that as a university, we are looking to further expand our work in the health sciences. We currently have programs in healthcare management and public health at the bachelor's and master's level, also a PhD in public health, and programs in occupational health and safety. And the Unicaf University in Zambia is looking soon to introduce some nursing and medical programs. I think with that, I'll pass briefly to my colleague Lamek Mwewa, in case he has a few words to say, and then we can move on with the with the main program. Thank you very much. Thank you.
Thank you, Dr. Ridley, and good afternoon, everyone. And I want to recognize the presence of those that are representing our very key stakeholders in the AIDS sector, the National AIDS Commission, the director in Malawi, and also Director General for the National AIDS Council here in Zambia. And also just want to welcome all the presenters that are going to share with us some insights of these very important aspects of society. I'll just want to introduce Dr. Kebi Sokotwane, who is the Director General for National AIDS Council, to deliver his welcome remarks. And then after that, we'll hand over to main presentations, which will be chaired by Dr. Mwaba, and Dr. Chela is going to make a special presentation on the perspectives of HIV rights and artificial intelligence. And thereafter, we'll have all these doctoral presentations that my colleague Robert Ridley has introduced. So again, sincere apologies from the Vice Chancellor, Dr. Piri Mshibwe, for Unicaf University in Zambia. She had an urgent call that she just had to leave in the last minute. But she wishes everyone the very best during this very important session of celebrating World AIDS Day. Thank you very much.
So I think maybe if we ask Kebi Musukutwani to maybe say a few words, introduce topic, and particularly with reference to the topic of World AIDS Day 2024, and maybe after she has spoken, Emily Kayimba can say a few words as well. So I pass the floor now to Kebi Musukutwani, and thank you very much again for gracing us with your presence this afternoon. Thank you very much.
Right. Good afternoon, everybody. Thank you very much. Greatly honored to be given this opportunity. I recognize the presence of Dr. Robert Ridley, Dr. Olga, Dr. Lamek Mwewa, and the leadership that is present for this meeting. I just put a few remarks together, if you allow me to just go ahead and quickly go through them now. So the interplay between human rights and HIV/AIDS in Zambia has been significant since the epidemic emerged in the 1980s, impacting thousands of lives and the nation's socioeconomic fabric. Women and children bear a disproportionate burden as caregivers, while the state struggles with economic strain of providing essential healthcare services. Upholding human rights is essential to overcoming barriers to effective HIV/AIDS and care treatment. HIV/AIDS is deeply influenced by global power dynamics and local socioeconomic factors such as poverty, gender, inequality, and human rights violations. A rights-based approach to healthcare ensures access to antiretroviral drugs, preventive measures, and treatment as fundamental human rights. Zambia has adopted international and regional human rights instruments, including the Universal Declaration of Human Rights, the International Covenant on Economic, Social, and Cultural Rights, the International Covenant on Civil, Political Rights, the African Charter on Human and People's Rights. Domestically, the Zambia National HIV/AIDS STI and TB policy of 1999, revised in 2005, emphasizes the non-discrimination confidentiality, and access to healthcare. Guidelines for the ethical HIV-related research were also developed by the National Research Ethics Committee. Despite these efforts, incidents of stigma and discrimination persist, undermining public health responses and exposing systemic weaknesses. Just to highlight some of the challenges, stigma and discrimination is persistent and it deters individuals from seeking care and exacerbates marginalization. Socioeconomic vulnerability, poverty and inequality hinder access to health services and heightened vulnerability to HIV/AIDS. Some opportunities identified: awareness and advocacy, increases public awareness and advocacy efforts which foster greater understanding of human rights in the context of HIV/AIDS. Community participation, involvement of the communities in program design enhances cultural relevance and acceptance. And finally, capacity building, the training of service providers in counseling and human rights helps address psychosocial barriers. Intersectionality highlights how overlapping social identities such as gender, sexual orientation, and socioeconomic status compound vulnerabilities to HIV/AIDS. Key populations in Zambia, including sex workers, men who have sex with men, transgender persons, prisoners, face significant barriers to healthcare due to stigma, discrimination, and the legal challenges. Some of the recommendations that I would make is to strengthen the human rights in the HIV response in Zambia. And these would take the form of enhancing legal protections, to develop a comprehensive legal framework addressing HIV/AIDS specific human rights issues, to educate the public on the rights of people living with HIV, to promote the non-discriminatory access to antiretroviral drugs and healthcare, and to ensure government, the judiciary, and civil society prioritize human rights in HIV policies and interventions, to mobilize people living with HIV to advocate for their rights and participate in policy making. In conclusion, addressing HIV/AIDS through a human rights-centered approach is critical to mitigating the epidemic's impact and ensuring dignity and equality for all. While progress has been made, sustained commitment to legal, social, and policy reforms is essential to protect and promote the rights of those affected. I conclude with those few remarks. Thank you very much. Over to you, Chair.
Thank you very much, Mr. Musukutwani. That was a very forceful outline of the issues, and if you like, a call to arms for action and putting human rights at the center of the approach to HIV and AIDS, and also giving us some insight into the Zambian situation. I'd like now to follow up maybe with Emily Kaimba, if she could also say a few words to help us set the scene for the talks that we're about to hear. And thank you again, Emily, for joining us at short notice when Beatrice was unable to attend. But we look forward to hearing from you. Thank you very much.
Thank you so much. As Robert has introduced me, my name is Emily Kaimba. I'm the director of Manaso. Manaso is a network of all HIV organizations that are implementing HIV activities in Malawi. And on behalf of the National AIDS Commission Executive Director, I'm deeply honored to speak before you today on this significant occasion as we observe the World AIDS Day 2024. This event serves as an important reminder of the challenges we continue to face in the fight against HIV and AIDS. But it is also a time to reflect on the progress we have made towards and to reaffirm our collective commitments to ending the HIV and the AIDS epidemic. I would like to extend my sincere thanks to Unicaf University for organizing this gathering and bringing us together to address one of the most important health challenges of our time. As we look back in 2023, we have much to celebrate. At Malawi, we have reached significant milestones in our efforts to combat HIV. Specifically, we achieved the 95-95-95 UNAIDS targets for 2025. This achievement was made possible through the strong collaboration of the government, academia, development partners, donors, and civil society. And the Manasseh and myself, I'm the civil society. Together, we have made remarkable strides really in improving the lives of those affected by HIV. In 2024, we have launched quite a number of new HIV initiatives in terms of HIV prevention. Just to mention a few is the injectable rape and also the differentiated HIV services, not forgetting the stand-home initiative. These efforts aim at further accelerating our progress and bringing us closer to our goal as we are aiming at ending AIDS by 2030. Despite these advancements, Malawi continues to bear the highest burden of HIV in the sub-Saharan region. In 2024, nearly 1 million people, that is 990,000 people, were living with HIV, which is a slight reduction from 1,012,000 people in 2023. While new infections have decreased to 14,000 from 19,000 in 2022, AIDS-related deaths remain at 11,300. These numbers highlight that while we have made progress, there's still much more to be done. Our theme this year is take the right path. Together, we can end AIDS. This is a powerful reminder that the journey towards the end of AIDS, by 2030, is not only about medical breakthroughs or scientific advancements. It is a call to action that reinforces the importance of human dignity, equality, and justice in the fight against HIV. As we reflect on the progress we have made, it is essential to acknowledge the pivotal role that research has played in shaping our response to HIV. And we know at the Unicaf University, you have also contributed a lot as an academic institution towards the research of ending AIDS by 2030. Research has really informed advocacy efforts that have led to policy changes aimed at protecting the rights of people living with HIV and the key populations. It has helped us identify the most obstacles as well to HIV prevention, treatment, such as the stigma, discrimination, and even criminalization. But equally important, we must recognize that research grounded in the human rights. We must recognize that research grounded in human rights framework is essential in creating meaningful change. A life-based approach in research goes beyond producing data or discovering new treatments. It ensures that the communities most affected by HIV are central to the research processes. By prioritizing human rights in research, we ensure that the voice of the people living with HIV and the other key populations are heard, protected, and acted upon. And I'm saying this knowing that Unicaf University is an academic university, really, and is also in research. As we look ahead to the goal of the AIDS-free society by 2030, we must work together to eliminate the barriers that continue to prevent people from accessing HIV prevention, treatment, and care. To achieve this, we must focus on the following. One, empowering communities. That is community-driven research is the key to delivering interventions that are relevant and socially appropriate and effective. We need to focus on strengthening advocacy for policy change. That is ensuring that we have evidence-based research that we can really advocate, and the Jude bearers hear what we are actually talking about, and they listen to and make changes that we want. And the third thing, which is also most important as we are discussing and as we are focusing ahead, is fighting stigma and discrimination. As stigma and discrimination remain major barrier to HIV prevention and care. So today, this is a call to action for all of us as individuals, organizations, even the government, to reaffirm our commitment to human dignity, equity, and the justice that we are even talked about. But by taking the right path, we can ensure that everyone, everywhere, has the opportunity to live a life free from the fear of HIV, and together we can end HIV. Together we can achieve the world where HIV is no longer a threat to health, well-being, and or even the human rights. Let us continue working hand in hand to create the future, because together we can end AIDS. So thank you so much for this opportunity. Thank you.
Thank you very much, Emily, for building on Kevi's presentation, reminding us that there's been a lot of progress, but there's still a lot to do, and that requires continuous attention and monitoring of progress. And I think, in your words, use the word campaigning and action to deliver on appropriate policy change and make sure that those policy changes are implemented to avoid discrimination and stigma, which lie at the center of the human rights-based approach. So I'd like to thank both Kebby and Emily for their introductions and scene-setting presentations. I think now I can pass over to Dr. Mwaba, who is going to chair the next session. Thank you very much again for our two eminent guests. Thank you.
All right. Thank you very much, Dr. Ridley, and thank you everyone for their presentations. So firstly, I would like to maybe introduce myself. So I'm Dr. Mwaba. I'm heading the public health department. I'm also helping coordinate with the doctoral studies program. So firstly, I would like to recognize the previous speakers and representatives from the National AIDS Councils from both Malawi and Zambia. And then I would like to thank everyone else who has made this opportunity to join us for this presentation. So before we proceed, let me just introduce our current speaker. So our current speaker will be Dr. Chela, who actually has a long history of fighting AIDS. So now he's actually has been the Director General for the National AIDS Council previously. So today he's going to honor us with a presentation on the perspectives of HIV and artificial intelligence. So in this presentation is trying to communicate to us the intersection between HIV and artificial intelligence or technology. So over to you, Dr. Chela.
Thank you very much, Dr. Mwaba, and good afternoon, everyone. All protocol observed. And I'd like to begin by stating that in a way, the discussion I'm going to launch into is actually a new area of discovery for HIV, because artificial intelligence is still developing. And really, what I will say today and the impact it has on human rights is still evolving. But I want to just sort of highlight a few things that I think are important for us to consider, because it will be a very, very interesting aspect of our response to the epidemic as we go forward. But just to begin, the issue of rights has been there for many years in Africa, in Asia, in the Western world, as individuals struggled for their independence. And it's an issue that still continues with HIV, with stigma, discrimination, lack of medical care, and in many populations. Some people can't see a doctor every year. And there's also a variety of access issues with regard to care and treatment services. Consequently, there is also discrimination that can occur, particularly with the use of AI. Therefore, it's urgent that human rights actors and advocates begin collaborating with technicians and health experts to determine how AI can be applied within the healthcare for HIV and to build the future that we all want to live in, the future that we want to see in years to come. Now, in applications relating to HIV prevention and treatment, one of the key AIs that we can look at is that of predictive analytics and machine learning. I'll try and keep the language very simple and sort of try to explain what this means. But analytic-driven technologies are technologies that enable public health officials to better identify high-risk populations, monitor trends, and inform how we can respond to the epidemic. And sometimes these are also used to develop initiatives that target limited resources and also approach the needs of vulnerable communities. The second type of artificial intelligence, besides predictive analytics and machine learning, is data mining. Data mining is basically where you look at large sets of data and use that data to actually innovate and see how that data can be applied to HIV protection, HIV care, and support. All of us remember COVID-19, and during COVID-19, there was a lot of use of AI, particularly in developing responses to COVID-19. And that lesson that we learned in COVID-19 can be applied to today's HIV epidemic. And I think one of the primary applications of predictive analytics in the fight against HIV and identifying high-risk individuals, and also how machine learning can be uniquely used to predict the way that particular outcomes in care can be identified and strategized and actually developed and enhanced is, I think, one of the ways that we can use artificial intelligence. We can apply artificial intelligence globally to determine how large amounts of data can then be used to predict the next steps for each care continuum, allowing for diagnosis, adherence, and eventual virus suppression of individuals identified as such. Now, at the patient level, the benefits of utilizing AI are clear in that it will focus primarily on promoting individualized patient care. And what I mean by individualized patient care is that it will improve the way that we care for individuals, particularly where they have vulnerabilities, or particularly where the diagnosis is not very clear, and where you need to be able to provide that particular care and service that they need. And here we're looking at individuals that may be vulnerable, for example, sex workers, people living with HIV/AIDS, men having sex with men, and key populations. I want to move on now to the legal implications and ethical implications of AI in human rights, because I think this is the crux of this discussion, where we're looking at human rights and how that impinges on HIV and on artificial intelligence. Firstly, the developments that are occurring in machine learning present a unique opportunity for effectiveness of human rights monitoring, advocacy, and facilitating broad-scale campaigns with more sophisticated analyses. This possibility, however, raises a number of ethical and legal issues. Such tools can be misused to discriminate against highly criminalized, highly marginalized communities. Like I said earlier, people who are sex workers, people who are taking drugs, or even people who are LGBTQI. And so their use raises the prospect of people living with HIV intentionally being criminalized by use of AI. Therefore, it is important for us to adopt AI in a compelling way that allows that it's best used to respect and protect and fulfill the human rights of these individuals. An ethical approach would also use these tools in a way that is right, a way that it is not misused. For example, are the programmers who are accountable for the predictions they make by the AI? And in what circumstances do they use those predictions? And do they provide us with real insights or fake insights? But more generally, the AI technology should be in line within human rights principles, and non-compliance may result in the fact that AI can be used against individuals. As well as ethical concerns, the development of and use of AI must also follow legal principles, many of which are enshrined in a number of frameworks in the support of data protection, legal protection for data, and also with the issue of the spread of treatment. It should be noted that there is a need for proper ethical consent, proper permissions to use the data from individuals and to protect their identity. And protection of their identity can be achieved through anonymization of personal data and making sure that those that are have access to this data have it in a way that they cannot use it to target individuals or use it against individuals that are identified. Additionally, policy concerns need to be developed in terms of how this data will be used. And in using AI, there are implications for the tools that are used and the transparency with which the tools are used. An example is using algorithms. And algorithms are used maybe to identify the way that individuals, for example, take their medication or collect their medication. And so this type of these algorithms should be able to be ethically and transparently used. An example would be if, for example, there's a black box and that black box has an algorithm in it, there needs to be an understanding of how that particular technology can be used to serve marginalized communities. These tools are likely to be extensively used in the future. But again, this is a discussion, an ongoing discussion between developers and technicians to see how we can maximize the use of the technology. Openness and capitalizing on the openness of these tools is also important, and these tools have to be interrogated by communities that are being helped. It cannot be that technicians and AI experts are the only ones that are interacting with this, but communities should be involved. But beyond the communities also, because a lot of the AI is driven by profit corporations, these need to be linked to health industries, but in an ethical way that preserves that innovation, but also preserves the human rights of individuals. This debate will continue, and it's ongoing, because innovation and the discharge of ethical responsibility is an important part of how AI will be used in the future. And so it's important that experts, service delivery providers, community leaders, and of course, people living with HIV/AIDS, who are the main beneficiaries of these projects, are involved right from the beginning. Now, lastly, I would like to conclude by looking at some of the challenges and the future directions we have in utilizing AI for human rights. Firstly, there's a growing number of applications that are being developed, and several challenges would arise from this. First of all, number one, technical hurdles and limitations may present themselves in harnessing AI for human rights, including access to diverse representative data. And something historical in the context of health is that it's very difficult sometimes to use this data because it may not apply to individuals with HIV. Secondly, we need to recognize that the nature of integration of AI into the health sector and the health system, where predictions are embedded between human relations and decisions, is very difficult. This has happened in the past, and I think we need to be aware of this and be able to have a fair deployment of AI. Thirdly and lastly, we have methods that are robust to cope with the real-world scenarios, and where we have imbalances and where data is missing, we need to be able to identify this and be able to ethically identify how we can fill that data gap. But from the societal perspective, it's also important to take into consideration how AI is used, particularly with the ethical, legal, and social concerns, and also in terms of stigma and discrimination that people with HIV are facing. Historically marginalized groups are victimized, and this could be perpetuated through the development of AI. And so we must take care of this. And so some of the challenges in this societal perspective in applying AI would include the following. Firstly, a cross-discipline collaboration to address these issues. So where you have health personnel, technicians, and others, and socioscientists and the community working together on the issues. The ongoing deployment of AI includes diverse voices, and bringing all these diverse voices into the AI model development and addressing this intersectorally is important. Lastly, but the third point is that advocating for policies that support more ethical access to AI and high quality interdisciplinary work on AI and human rights is called for. In conclusion, given these challenges, AI has a potential to have a huge impact in advancing HIV/AIDS rights, but only if we ensure that such issues are tackled thoroughly and with careful interdisciplinary consideration. Thank you very much.
All right. Thank you very much for that presentation, Dr. Chela. So maybe this is the time now we'll start receiving some questions. So to everyone, we have a Q&A button or section where you can just type in your questions and then I'll be able to read them out. So we already have some questions. So the first question is coming in from Adianto, who's one of our PhD students. He's from Indonesia. So he has two questions. I think I'll ask you in tandem. I'll allow you to answer one and then I'll come in with the next one. So Adianto writes, from the HIV explanation, also COVID experience a few years ago, I have the two questions. So the first question is, what lessons can be learned from the successes and shortcomings of global HIV prevention and COVID-19 containment efforts in addressing the stigma and inequality in healthcare access for future pandemics? May I know a socio-economic and public health policy angle? So maybe I read this question again. What lessons can be learned from the successes and shortcomings of global HIV prevention and COVID-19 containment efforts in addressing the stigma and inequality in healthcare access for future pandemics? May I know a socio-economic and public health policy angle? Over to you, Dr. Chela. Oh, Doc, your mic
Sorry,
is
I was
muted.
on mute.
Yeah.
Hadianto, thank you for your question. It's a very brilliant question because it raises several issues that I think we need to be aware of. If you remember, COVID-19, we learned that working together across various groups and not leaving data in containers was a very positive way of quickly developing the vaccine. So sharing information is a lesson that can be learned. And that has a socioeconomic implication because the cost of developing the robust HIV treatments can also be enhanced by sharing some of the lessons that we learned in developing COVID-19 vaccine. And from a public health policy angle, I think we learned from COVID-19, for example, if we pull data from various sources, that can help us see how the epidemic is spreading. And I think sometimes we haven't done that with HIV. And so there's some experience that we need to take from that. Another example is where we pull data from, sewers. And that way we were able to identify where COVID-19 was going. And so there's a lot of lessons we can learn from the issue of COVID-19. And also with stigma. I think with COVID-19, we learned that stigma occurs when we identify when individuals were identified as having COVID-19. But increasingly, there was a lot of information that came out to let people know that it's preventable, it's something that's containable, and you shouldn't discriminate. And if you do get yourself exposed, then you can get a vaccine or you can get some cure or some treatment. So I think those lessons can be applied to human rights and with HIV. Thank you.
Right, thank you. I'll proceed to the next question, the last question from Adianto. So the question is, from a technological and diagnostic innovation lens, especially looking at AI, how can advancements in diagnostic technologies for HIV such as point of care testing and viral load monitoring, be adapted or improved to enhance real-time tracking and rapid response for respiratory viruses like the SARS-CoV-2 and future pandemic pathogens?
Hadianto, thank you for your second question. I think diagnostic technologies for HIV, like point of care testing and viral load monitoring, are very important. And I think if you remember what we did with COVID-19, we actually were able to develop, these were like DNA trees of how the virus was spreading and changing and mutating. I think there's a lot we can adapt from that to improve our enhancement of tracking of HIV. Because I think increasingly we are in a position where we have resistance to HIV occurring, to drugs, and this can be tracked using various technologies. And I think the approach that we use with SARS-CoV-2 would be a very important lesson for us to take and take forward. I think increasingly countries like in Africa also need to go beyond just simply collecting data, but also identifying how that information from point of care and viral load monitoring can be used for decision making. A lot of times data sits and is not utilized adequately. So I'm calling that for that kind of use to occur, particularly where we have now a way of quantifying or looking at data using machine learning or using AI tools that can summarize very quickly what that information means and what that information means for decision making. So I think that's one way we can use diagnostic information. Thank you.
Right. Thank you. So just a quick question from Dr. Msokotwane. So from his experience, data quality is key in ensuring that any of the tools we employ are useful. So how can the advances in AI be harnessed to ensure that the data we see is accurate and therefore useful for planning and program design?
Okay, thank you, Dr. Msokotwane. One of the ways I think we can use the HIV data is to try and use that data in mapping. Now, it's not just data about illness, but it's also data about service provision. I remember when I was in Director General of National AIDS Council many years ago, we had this map where you could actually see where you can get your services from. That map has disappeared. I don't know what happened. So it would be very useful if we can use AI now to develop maps that show you where the best drugs are, where the drugs are available. And this is an open source map that people can look at and see where they can get their treatments, where they can get their the effective HIV services. And all this can be done through AI. And then again, integrating our health management information system from the Ministry of Health with the data that we have with the HIV/AIDS program, but also linking this to data that is socially available and using social media and social media tools and social media like WhatsApp, Facebook, and Twitter and TikTok to try and communicate what is happening is I think critical. So having a cross-platform that's available to most people with HIV using AI would be important. Let me also just state that not many people have smartphones, so we must begin to use USSD as one of the other ways that we can communicate information that's developed from AI to patients who have HIV. Thank you.
Right, thank you. So we have another question. This is coming from Yenu. So it says, the idea is very impressive. So what is the implantation rate for AI for HIV patients globally?
Well, AI in HIV globally is still in its infancy, but there are some countries that actually have implemented successful AI for patients, particularly in developed countries. I think there is a need for lessons to be learned and lessons to be shared, like we talked about how we did this in COVID. And that way we can begin to collaborate across many of the countries, either south to south collaboration or north to south collaboration, so that we can use these AI tools to help patients globally. But again, the emphasis should also be in this particular discussion where we focus on how AI implementation assists in human rights, allowing people to have the rights to do things and also accessibility to treatment, care, and support.
All right, thank you for that. So we have the next question coming in from Dr. Nwandwe. So the question is, I would like to know about the level of a person who takes D17 pills and deciding whether to take the TOD or PEP pills.
Oh, this is a medical question. I can't answer that question, but I think that there's a level at which one has to decide whether PEP or TDL is the way to go forward. But I guess you would want to identify these individuals and carefully provide those medications, because depending on their profile and how they've been taking their medication is important to consider. And you wouldn't want to change their medication profile because there are implications for doing that, but also there are cost implications for doing that, changing from one regimen to another regimen.
Yeah, thank you. So the next question is from Melissa. So how has the introduction of the proposed vaccine for HIV affected the achievement of the 95-95-95 goal? Also, after achievement of the goals, what next?
I think the 95-95-95 goals are great. And I think what's key here is to sustain this, because, you know, with time, we can have a deterioration of the achievements that we've made. And in Zambia in particular, we've seen this quite clearly, where younger people are now more infected by HIV and affected by HIV and lack of information. So in introducing a vaccine, it doesn't obviate your responsibility for HIV prevention using conventional means. And I think that's what I think is important in introduction of this vaccine. We need to still emphasize the basics of HIV prevention and ensure that information, condom use, one sexual partner is still the message. And I think sometimes that doesn't continue over time. And I think there's no historical recollection of the impact of losing that knowledge. So that's, I think, one of the challenges we have with the proposed vaccine. People will think it's a solution, a magic bullet. It's not.
Right. Thank you. So the next question from Peter says, how do we balance innovation with ethical considerations? So such as informed consent. Just give me a second. Such as informed consent and cultural sensitivity when it comes to over-reliance on technology.
I think that innovation is good. And I think that with the coming of AI, one needs to be able to still be able to use the basic ethical principles. Basic ethical principles really don't change in medicine and in the care of individuals. And I think we need to get to understand the ethical background and ethical basis of care and still use that. And also, there is that cultural sensitivity that's needed. Increasingly younger people are more reliant on technology. So I think there's an important balance between technology and the old ways that we did things. And maybe it's time for younger people to interact more with older doctors like myself, so that you can learn what we used to do when there was no technology. There were days when we were not using technology at all. And I'm very surprised today you go into a hospital and the doctor's looking at his phone half of the time, or he's on his computer half of the time typing away. They don't even touch you. That's an over-reliance on technology. We need to go back and see how we cared for individuals in the past and try and mix the two together.
Yeah. Thank you. So the next question from Nubem says, from the presentations, the only things that point to efforts towards prevention are research and advocacy. So what are we doing to prevent new cases from springing up? If we intend to end HIV and AIDS. Therefore, there should be a formidable preventative strategy.
Yeah, a lot of questions coming towards me. Would you like me to answer that, or would you like someone else to answer it? But just to sort of give you my view on that one, I think, there's no one formidable preventative strategy. I think it's combination prevention, where you combine various components to prevent HIV transmission, information, information about condom use, treatment, care, and support. All of these combination prevention strategies are important to take into consideration. And particularly when we look at medication, we need to begin to think more about how medication can be preventative and using that paradigm to actually move forward in preventing further spread of HIV.
Thank you. Just to our panelists, if any panelists would also like to answer any of our questions, please feel free. So the next question comes in from Laurette. So, hello, my name is Laurette from Rwanda. So she's one of our PhD students. So in Rwanda, according to the recent research, 3.7% of HIV patients are women, while only 2.2 are men. If it is the same number in other countries, how can we reduce this increase since women are at risk of passing it easily to their children? Oh, you got that, Dr. Shella? So
Yes, I did. I thought another panelist would take up the question, but Laurette, thank you very much for the question from Rwanda. And I think it's important for us to know that HIV is more prevalent in women because of their vulnerabilities and their exposure to HIV than to men. And I think what's important here is that in order to prevent the transmission to their children, I think a lot of effort needs to be put into putting in preventative measures, like, for example, PMTCT services, but also ensuring that care and support for women when they are pregnant is put in place, particularly with regard to access to maternal and child health services that are affordable and are able to be accessed quickly within a short distance. Some of these strategies are very easy to implement. And I think in Rwanda, a small country, this is very possible. Bigger countries, again, can also begin to do this. And I think there is a point in case where we can actually promote women coming to delivery centers earlier, but also promote the involvement of men in maternal and child health care.
Yes, maybe I can also just add in a bit on this. So I remember I was way back, I think that was somewhere in 2010, 20 something. We were doing a randomized clinical trial to prevent mother-to-child transmission through the breast milk. So coincidentally, amongst the multi-sites, Rwanda was one of them. There was Zambia, and then there was also South Africa. So I think when you check, there are actual intended efforts to try and prevent this vertical and horizontal transmission. So in this case, the children were being given the antiretrovirals to prevent transmission through the breast milk. So I think the current transmission rates, then the transmission rates were around 5%, but then the antiretrovirals introduced, I think they reduced the transmission to 2%. So there's actually a lot of work which is trying to optimize treatment for the mother and the child currently. So thank you very much for the answer, Dr. Chela. So we move on to the next question. So Annette says, this is a great exposure, HIV challenges in Uganda as well. So I wonder about issues regarding HIV and secondary school students. So please elaborate on this.
With regard to HIV and secondary school students, I think the important point there is to provide information, but also provide sensitive school health services. And within that context, the school health services can decide what kind of HIV preventative tools and strategies that can be adopted. But basically, information and integrating that within the school curriculum is important. But above and beyond that, I think there's a need to have sexual and reproductive health services at clinics that are sensitive to secondary school students. Sometimes there's stigmatization, sometimes there's victimization, and actually judgment, because an individual from a secondary school who's trying to access sexual reproductive health services is made to feel they are wrong by accessing these services. So I think there's a need also to train health staff in those services about how they can treat secondary school students in a more humane and ethical way that will help them prevent spread of HIV. The alternative is that they will just not go to the service and they'll spread HIV or catch HIV.
Thank you for that. So the next question comes in from Jones. Let me just take the time. Okay, so we have 5 minutes for this session, just to keep everyone with time. So Jones says, hello, I'm Dr. Jones, a master's student in Uganda. So his question is, how will AI play its role in promoting human rights and fighting stigma? Yet we know uptake of technology remains low in rural areas, especially in Africa. So this is his first question. The second question, I think, is a bit related, says, what role has AI played in developing the HIV vaccine and discovery of newer ARVs that are more effective? I think you had alluded a bit to this second question in your presentation as well.
Okay, Dr. Jones, thank you very much for your question about the role of AI in human rights. I think one of the ways that we can promote human rights and fight stigma is to, for example, identify where good services are available. And this can be done by collecting information from these service providers, both public and private, and then identifying where care and support is the best. And individuals will begin to identify, maybe on a map or maybe using USSD in rural areas where you don't have smartphones, identify which are the best service providers. And I think going forward, those service providers can be identified and helped to promote the services that they provide. And in that way, stigma can be fought, and those that are stigmatizing can be identified and maybe trained. Again, AI can do all this, and there are various ways we can do research looking at how we promote human rights and fight stigma. The second question about how we develop the HIV vaccine or new ARVs is that AI has been very instrumental in developing the necessary changes to existing ARV and HIV drugs and even vaccines. It's much quicker for you to actually develop vaccines within a container meaning a software that can actually change the structure of your medication. But also beyond that, you can actually identify the impact of that change in your structure of your vaccine or your medication. So AI has been helping in developing this and making sure that we can develop changes with drugs or resistance in a much quicker way. And then that way we can bring drug development much quicker to the market. So that's one way that AI is helping. Let me just say one last thing about AI and drug development is that there are companies that actually have basic, the building blocks for a drug development. And so that there is no longer any need to be developing the actual building blocks, because we can actually access what is existing within software containers, where we can actually sort of play around with blocks of the medications and see whether they're effective in that particular sandbox.
Yeah. Thank you for that. So I think your last answer even answers the question from Abdulaziz Mohammed, who was asking, can AI be used for designing of vaccines for HIV? So I think I'll move on to the question from Dr. Kamel. So Dr. Kamel from Republic Democratic of Congo. So he's asking, why do pharmaceutical companies mainly focus on improving antiretrovirals rather than creating a molecule that can eradicate the HIV?
Well,
So
I think it's not easy to eradicate HIV because HIV has it changes very quickly sometimes, and we can't pin it down and eliminate it. And also, it's the nature of the spread of the virus that causes it to actually mutate and continue even today. Much less, of course, with prevention, care, and support. But I think increasingly, I think pharmaceuticals need to work together with communities to identify how these molecules can be developed to benefit communities. One of the ways this has been done is that, for example, here in Zambia, local medications have been tested and found to be effective, and these can be promoted. But then there's also, I think, a very important point to make here, that the development of drugs, or the process to development of drugs, is very expensive. And so drug companies will go the shortest and cheapest route. And again, they will not end the epidemic because of that. And again, increasingly, I think we need to also look at the cost element, so that we find that the antiretrovirals can be less costly. And that hopefully will allow more of the antiretrovirals to be available to more people. And that way will reduce viral load within communities.
yeah. Thank you. I think we have run out of time, but then just in conclusion, as an addition to this same question, I'm involved in a study we're calling the HIV cure research. So this is actually a global effort, so focused on HIV reservoir. So the main problem with HIV is it remains dormant for a really extended period of time. Current medications are very effective for clearing the free HIV, but then now the HIV, which is intracellular, that is the main problem. So if you just check on the internet regarding methods such as the shock and kill, so shock and kill just looks for those, tries to activate the latent HIV to make it active in replication, and then so that it can be cleared. So none of these technologies are yet to be approved to the level where they can now be given as treatment. So there's actually a lot happening in the basic science background of it before it, I think, proceeds to the clinical. So thank you very much, Dr. Chela. So is there anything in summary you would like to say?
Well, in summary, I think I would say that there's a lot of work we have to do going forward. But I think there are a lot of tools now that we have that can help us. And AI is a particular tool that we must take advantage of and use more effectively. Thank you.
All right. Thank you. So I would like to hand over to Dr. Ridley. Thank you.
Thank you very much for that presentation. And I think just to add to what Dr. Mwaba said at the end, I think the issue with drugs that can actually eradicate HIV or vaccines, it's not just an issue of cost, it is an issue of, it's very hard to achieve it scientifically. So I think, we're right at the edge of our technological capacity when we're talking about that sort of medical intervention. I think now I'd like to, after that very interesting discussion, I'd like to pass the floor to Wilfred Maceo, who will chair the next session, which is introducing the work of some of our PhD students. Wilfred, over to you, and I'll allow you to introduce yourself. Thank you very much.
Yeah, thank you, VC. So I'm Wilfred Maseo, an associate professor and dean based at Unicaf University here in Malawi. We have two doctoral students who will be presenting on their work. And the first one is Nkamsire Dlamini Twala. Her research is an exploratory study of PA sexuality education among young people in Eswatini. So she will have 15 minutes to present, and thereafter we'll have Nokwazi Blanga Matabela. And her topic is policy option for co-sharing costs of lifelong antiretroviral treatment by involving people living with HIV in the Kingdom of Eswatini. And again, after the presentation of the two is when the floor will be open for discussions. So you type your questions and our presenters will provide responses. So, Musire, the floor is open for you. Thank you.
I would like to confirm that, Nkamsire, you wanted us to share our screen, yes? Is that correct?
Yes, please. Yes.
Okay, I'm sharing the screen. Just confirm with me that you can see the screen.
Yes, I can see. Please put it on share. Yes, that's perfect. Thank you.
You may start.
I can proceed. Okay, thank you so much. And I just want to appreciate the opportunity to share a piece of my work with everyone in the meeting, and just to recognize also the protocol, appreciating the vice chancellors that are in the meeting, also the stakeholders that are providing oversight in terms of the HIV and AIDS response in the two countries, that is Malawi and Zambia, and also just the entire leadership of Unicaf University for Malawi and Zambia. So yes, my study is on trying to explore the experiences of young people that have gone through PA sexuality education in the communities in Eswatini. Next slide. Yes, so this is the outline. We'll just go through a brief introduction of the study, background, and then research questions, then methodology, findings, and how it contributes to the HIV response. Next slide. So I think the presenters that have gone before me, they've already highlighted that we have an issue among young people. They are the ones that are mostly exposed to HIV infection, having half of all new infections among the young people. And this is just not in Sub-Saharan Africa. Of course, Sub-Saharan Africa is the one that is hard hit, but globally, we are having a problem among young people. So sexuality education has been one strategy that has been used across the globe in terms of responding to HIV for young people. So sexuality education, what it entails is just the HIV prevention education, sexual and reproductive health that focuses on STI, contraception, and condom use, and then providing services for HIV testing, PrEP, which are new commodities that are coming into the market, and then also ART treatment. And most importantly, it also equips young people on gender-based violence, which not just gender-based violence, but you want to make sure that there's also gender norms, because understanding gender norms, how they fit into GBV, then it assists. And then also it empowers young people on economic empowerment, which also stems out, to make them vulnerable because of survival, then they tend to engage in risky sexual behaviors. So the rationale of sexual education, it's the right to health and information. The other speakers have already shared that as well on this one, to say it is a right for young people to have the correct information. And this is supposed to be scientific information, so that they are informed about the available options and they are able to make the decisions. And also just bearing in mind that HIV is not just, they're not exposed just because they are not accessing medication and so forth, but it also has that gender lens, from it, because they are deprived, and sometimes even if they want to employ protective measures, they are not able to do so because of the fear of gender-based violence and because of the male supremacy over young women and women in general. So persistently HIV transmission rates suggest that young people are not constantly adopting the HIV prevention and protective measures against STI, HIV. So investment in sexual education and HIV education has not yielded the positive outcomes. I think we'll all note that in most countries, there's a huge investment on HIV, but what is the issue among this population? Next slide. So the research questions were, what is the uptake of HIV prevention services among young people? And then what are their experiences and barriers in the application of the HIV prevention in their sexual behaviors? And then what are the observations of service providers on sexuality education delivered in the communities? And then what are the needs and recommendations for sexuality education programs for young people? Next slide. So the study was conducted in 4 communities in Eswatini, highlighted in those pink dots. So most of those communities, one of them, which is on the far left, is closer to our capital city, but also closer to our main border post. And then the one up there, it's closer to the border post that we have with South Africa as well. And then there's a mining town next to that one, which is Peaks Peak. And then Mhlangatane is one that borders both with South Africa and Mozambique. So these are mainly rural communities, except the one that is closer to Mbabane, which is our capital city. So this was a qualitative study. The young people were engaged in focus group discussions. And then also I conducted key informant interviews with the peer educators and also a Ministry of Health representative who is providing oversight on the adolescent health services. So the sites that we selected were sites that had young people that have gone through the entire curriculum of sexuality education. Then assuming that once you've gone through the the entire curriculum, you have been equipped with the skills to be able to be assertive and stand for the decisions that you've made. So 81 young people were engaged in these FGDs, which are both men and young women. And then also the life mentors, who are the peer educators, and then the MOH representative. Next slide. Yes, so the findings in terms of the uptake of HIV prevention services. One, it was good to know, that at least they are attending the sessions that are happening in terms of sexuality education, and they are able to cover, the entire curriculum. And then also they were able to get tested on site, because the program was also bringing services on site in the communities where they were getting the sessions. And then what was noted again is that there's low PrEP uptake, for the services that were among the services that were provided, and also they utilized oral contraception. They were able to take that, but of course I would indicate more on the barriers why the oral contraception was not also effectively used. And then there was also interest in gender-based violence reporting. And then there was also participation in the economic activities that were introduced by the program, which is mainly focusing on vocational skills training. And then, okay, what are the experiences then on and the barriers in application of this, knowledge that they have in their sexual behaviors? So there was partner resistance in condom use, and then limited availability of contraception. And also the partners were also not supportive of the contraception use, citing a lot of myths around contraception. And then there was also inadequate knowledge on for PrEP, PEP, and STI. And hence, for PrEP, there was low uptake. And then for STI, they were just not, they would want to go to the facility. However, they were not able to go there because because of the issue with the judgmental attitudes for healthcare workers, and also the partners would not want to go for the STI treatment. And then the other barrier was the intergenerational sex relationships and transactional sex, which made them not to have the assertiveness and challenge the non-use of protective measures. So they would then now give in. And the other reason for giving in is that they fear violence, especially with these elder partners. They would fear the violence, and therefore they would then retract and make sure that they just allow the partner then to have sex in any way they please, because they now fearing violence. And then also when they've taken alcohol, they would not be able to make the decisions whether to use a condom or not. They'll just have sex anyhow. And then also limited capacity of the life mentors, where the peer educators, they were not able to market effectively the biomedical prevention services like PrEP. And therefore, because they were not able to deliver that, then the young people were not compelled then to take on PrEP. And yet it's the one method that is there, which they can use to prevent HIV infection. And then also gender-based violence, they were trained on sensitized on gender-based violence, but because they were not now equipped in terms of the specific norms that elevate them, to GBV, then they were not able, to stand up against it, such that when they fear violence, they easily give in and not use protection. And then there's also the issue of HIV stigma and discrimination. Even among the couples, they were not able to share their HIV status, with the partners, and therefore sometimes they would engage in unprotected sex without even knowing the HIV status of the partner, and therefore they'll then get HIV. And then there's also the issue of parents not being able to communicate about sexuality with their children, just to give them the facts and so forth. We know that the parents, they socialize children, and children normally want to adhere to what their parents are saying. And because now the parents are saying it's not their place, it's either the place of the school to teach about life skills and sexuality, and also the elders. But in the current situation where we are, we know that there's been a lot of disintegration within families. So the children now, they don't have a space in the family where they are getting educated and being guided in terms of sexuality. Next slide. So the observations among the service providers, those are the life mentors and also Ministry of Health. So they have also observed that there's an increase of uptake among young people on HIV testing. However, what is just worth noting here is that even though there's increase of HIV testing, they're just testing just to make sure that they know that they're still not HIV positive, but not necessarily employing protective measures towards getting HIV and AIDS. And then the alcohol abuse, I think for those that have gone through the entire curriculum, I think they've been sensitized a bit. So now they are still drinking, but they are seeing that at least now there's that moderation. And then there's a lack of involvement of community leadership and parents in the entire, education and support, such that some were reporting that their parents, they refuse that they go into the education sessions because they're going to be taught about how to initiate sex and start, engaging in those sexual practices. And then young men also were demanding for services. I think some of the interventions now were being targeted mostly to women, young women instead of men. So young men will be deprived. And even if there are mobile clinic services that are provided, the priority was given to young women. So young men were also then complaining. And then there was also a lack of coordination for sexuality education programs. Like every NGO in the community, they come with their own curricula, they come with all their own interventions and just implement however they want. So there's just no standard way of implementing sexuality education interventions at community level. And then some of the needs and recommendations for sexuality education programs for young people. The young people themselves, they did request that they would want to know more about biomedical prevention services like PrEP, PEP, STI, and VMMC, because those are the ones that they were not so clear of in terms of their benefits, and efficacy towards HIV prevention. So they wanted more information. STI was even more interesting because they were saying it's these young women that go out with elder men who just then transmit the infection to them. So they would really want to understand how they can stop these young women from infecting them, because at the end of the day, when the elder men have gone, then they come to the younger men. And then there's also that cry to say, if young men can be involved in this program fully, they'll be able to support the use of contraception. They'll be able to understand STI and make sure that they go as a couple, to seek healthcare so that they are both treated for STI. And then co-creation on program design and implementation with stakeholders. Because as I highlighted earlier, the parents in the communities and also some of the community leadership, they did not want implementation of the sexuality education program in the communities because of the assumption that children, they are now going to be sensitized on sexual activities, and therefore they would want to explore them at a younger age. Next slide. So contribution to the HIV interventions or response. So education of young people is a right. They have a right to information. So they have a right to also have a know-how in terms of their sexuality, because adolescence is a passage. It's a transition stage, and everyone going through that stage needs to be equipped so that whatever pressures that occur as they're going through that stage, they have the knowledge and they know where to access information. And if it's a service that they require, they are able to get that. So then we need to make sure that the adapted curriculums, they include human rights, sexual orientation, and gender norms. Because in as much as some of the services were there, but because of the gender norms that are in the play, then they're not able to take on these services, because I have to make sure that my partner agrees for me to use a condom. My partner agrees that we go for STI treatment in the facility. So some of those things, if the gender norms are not articulated well in the sessions, and also human rights, they are not able to stand for. And some of them are even highlighting that even when they report this to their parents say, no, you have to make sure that you respect your partner, and whatever he says is your authority, and so forth. So those are some of the things that we need to make sure that at least are being addressed. And then stakeholder involvement in curriculum development, so that this curriculum, one, is known by these local structures, and it's already sensitive to all the cultures and the norms. Because the issue now is that they will be complaining to say, you're bringing foreign content into our communities. Therefore, we don't want our children to participate. So stakeholder involvement in whether the curriculum is being adapted or being developed is critical, so that even all these religious beliefs, if those religious leaders are involved, then it assists in terms of making sure that it culturally, they have that cultural sensitivity in the curriculum. And then stigma-free health services is also a human right, because we want to make sure that everyone has access to access to health. So the change in healthcare worker attitudes is required, for young people to access friendly services, because some of them, they would know that now I have an STI, I would want to seek healthcare services. However, they're not able to go there because the healthcare workers are judging them at a young age. You are now engaging in sex and so forth. So then that deters them from seeking healthcare. And then collaboration with NGOs to provide information on biomedical prevention services and SRH services. So here, like the health representative indicated, that we need to make sure that as the non-governmental organizations are providing the education in the communities, the SRH services are supposed to be provided on site, so that the health workers who are professionals are able now to educate the young people on the clinical services, and be able to, to address all the myths, all these misconceptions around biomedical prevention services. Because at the level of the peer educator who is working for an NGO, they are not able to articulate effectively, the efficacy and the benefits of the biomedical prevention services. Then GBV and gender norms, changing the harmful sociocultural norms, like saying sexuality is a taboo and so forth. Sexuality is not a taboo. Everyone who is an adult has gone through that adolescent stage. And in an adolescent stage, if I'm not getting the information and I'm told that they're not going to talk to me about sexuality because I'm still young, they only talk to me when I'm now about to get married and being prepared for the men that I'm going to meet, then it creates issues, both for the men and for the young women. Because men are now told to say, because of authority, this is what you accept from a woman. And the woman is saying, for anything, you just have to submit. So those things, they need to make sure that now young people, are educated to be able, to challenge some of the harmful norms that they may come across. And then parents and traditional religious leaders as well, they're supposed to champion the education to be able, to provide that protective environment at a household level and also at the community. Yes. I think that's the last point. Yes. Hello. Yes, that's the last point.
Lap up, yeah. Good.
Yes. Yes. So sexuality education needed for young people to assert on decisions regarding their sexual matters. So I think next slide. I think that was the last slide. Okay, this is the okay. I think here maybe I can just say operationalization and accountability on the frameworks of sexuality education. Governments have committed at sub-Saharan level and also globally to implement sexuality education in countries. However, we are not seeing the political will now in operationalizing those at country level. And then sexual health as a human right, that I cannot overemphasize. We have to make sure that everyone they attain the access to sexuality education and also sexual health information services from healthcare professionals, because they need to know the correct information. And then as they access the information, the health services or SRH services are supposed to be provided, so that at least once they are, they are convicted on the information, they are able to access and tap into the, the services to be able to provide, to prevent any further STI or HIV infections. I thank you.
Thank you. So participants keep on typing the questions. We'll ask them later after we hear from Nokwazi Mlanga Matabera. You have 15 minutes, Nokwazi.
Thank you, Dr. Wilfred. Good afternoon, VC, DG, panelists, supervisors, and everyone in attendance. Olga, please may you project my presentation.
Yes, sure.
Yes, my study is about financing HIV treatment, the long-term implications, because as a world, we have sent word, next slide, please. We have sent word on universal access to treatment, starting PLHIV early from the early stage where we used to have the disease progression and then put them in there. And then suddenly we said that let them go in there. There are some benefits for going in there, benefits for their own health, and also benefits for HIV prevention as a drive to achieve epidemic control. So now the challenge becomes that, so countries like Eswatini now has a commitment to maintain almost 20% on its population on a free program, because most HIV programs are free. And if you look at the figure on the right, it's just the flow of the epidemiology that we are the bottom blue. There's 1.1 million people in Eswatini. Green, more of them are negative. Red, 200, over 200 are positive. But if you go to the top, you see that year on year, we almost, this one is for 2021, we get 6,000, almost 6,500 new infections. And most of these new infections come from that earlier presentation from Namsile. It's predominantly adolescent and young girls, and these ones are younger. They will stay longer on treatment. And for Eswatini, our treatment bill is largely financed by the government of Eswatini. They are now supporting 40% of the entire response, but almost 100% of the ARVs. So anything ARVs touches on government. Please go to the next slide. So the problem is that picture on the right. This one is for just 9 days ago, World AIDS Day commemoration. PLHIV themselves presenting, saying they're worried about Eswatini's drug shortages. So Eswatini is that its health system is showing signs of strain. We are seeing some drug shortages of the others, dialysis medicine, Panados, but the government has been strategic in that we have been safeguarding the ARVs. So now it's opportune to start the discussion of saying, can you sustain the free program? Because clearly government has limited space in Eswatini. We also have high poverty, we have ODA, we have a big social protection system, free primary education, elderly grants. So government has all these commitments. And so when you look at scholars define the bill for HIV treatment as sometimes it can be looked at as public debt that governments cannot renege out of, especially for the risk of a reversal in the health outcomes of PLHIV, health in itself, and then also the spike in viral load, which can have feedback onto prevention. So it would be disastrous to really say we can even take a chance on letting this population take a risk on that. So the study is a case study to say, we can, Eswatini, to estimate the long-term demands of that treatment bill, quantify the contribution, if any, PLHIV who are willing, one, and able to finance it. And this is also guided, next slide, by scholars who say willingness is one thing, but it's going to be the ability. I would like to buy myself anything, but can I really afford it? And the result, the design is that it's a mixed methods. On one part, I perform secondary analysis of quantitative data from existing national surveys, existing national accounts data, and the addition is the primary qualitative data collection aspect to really gather from the PLHIV and other populations on the willingness and ability that can PLHIV play a role. And this one, it's not a crazy question, because in other diseases, I have blood pressure, I purchase my own medicines. So there's that debate that what makes this illness special. So it's also that. So I address it through 3 questions. One, what is the cost of getting ART to all PLHIV? 2, and what extent can people living with HIV contribute? And that's the willingness and also the affordability. And also to see if savings, if they would contribute, what are the savings that would be made? Because the government would make a saving as well, which would contribute to the other development challenges. Thank you. Next slide. So in the first question, I address it through 3 steps. The first one is fiscal capacity. Can my government afford that? Looking at key indicators, I look at macroeconomic indicators. There are scholars, Calmore and Wood. They recommended 12 predictors of fiscal ability to sustain HIV programs. And I look at those for Eswatini, if Eswatini is having positive indices for those ones. And I also look at the demand for ART. The demand for ART is mainly the population of people living with HIV, and also then quantifying that demand into a resources need. Next slide. So I've just taken only 2 of those indicators to just show the situation. If you look at the left, it's the government fiscus, and the green one is the revenues. Sorry, word is missing. It's the word reads total. The green is the revenues. You can see the expenditures in red. So government is operating at a fiscal deficit, which is dotted at the bottom. So government is operating at a deficit. That's a problem. So it means there's no money. And if you move to the right, you look at the government, the public debt, because these are liabilities for government. And I looked at public debt from 2 main sources, from the domestic sources and external sources. And what is peculiar with Eswatini is that we have a more domestic debt than external debt. And the problem with this in economics is that it's crowding out as well the private sector, which could be investing to kickstart the economy, and the government would get taxes, etc., etc. So even that is not a good sign. And you look at the aggregators that Eswatini operates on almost 40% of public debt. So macroeconomics says we are not doing well. Please move to the next slide. The next slide, I just looked at the health and HIV indicators. On the left, current health expenditures by the funding scheme. Where does money come from for health financing? And if you look at it there, you will see that shaded on the left, the 48%. So indeed, government is the major single financier for HIV schemes. And you can see some participation of other players and most critically for me is that one, the voluntary healthcare payment schemes, which for me is the insurances. So I am also going to be checking on that indicator to see, because that one is safeguarded, at least it's health insurance. Whether anything happens to government, that would safeguard that cost. And if you come to the right, I'm sorry, my slides are not clear. I just noticed now. And if you look at the red, the bottom on that red on that column is the HIV and STIs. So current health expenditure for Eswatini, more than a quarter of all the diseases that we can see is spent on HIV. So for Eswatini, HIV is a big deal, and anything on it is a problem. Please go to the next slide. And then the step 2 on looking at the demand. The demand, again, if you look at the left, you can see that new infections, which is the red line, is higher than the AIDS deaths. So, and the projection shows that this will continue to be the trend. So it means that that population of PLHIV without a lot of AIDS deaths means will remain either flat, stable at the 200,000, or even grow if that type of new infections would be exposed. And then on the right is the PLHIV population in itself. And you can see as we approach the 2030s, we will still be running with 216,000, 20% of the population. So that bill will still exist. Next slide. And under the need receive, in terms of whether is government already committed to this, I think that's a good one, because government, that's the receiving artists is PLHIV who are already on the program. Therefore, government, it's the current cohort of PLHIV. So we're at about 92% of PLHIV. This one is for 15 and older, who are already on ARVs. So the difference that government would feel if today would be only just 8%, all of them just enrolled. So that's some comfort that at least you're going on with a bill that you've already taken the largest chunk of the cohort of the PLHIV population. Next slide. And in terms of the projection of the fiscal costs, my government is still giving me a better cost, but I was able to do for the first line ARVs. We are seeing that it is continuing to grow, and that is the first line of treatment that patients are normally given. And if you look at the aging with diseases, as they stay longer on treatment, there's just the general aging, the non-communicable diseases, and also then there'll be also resistance issues. So first line is cheaper. As the projection moves forward, we will see some give and take between the first and second line, because the older ones are going to require stronger regimen, and that bill is still going to be high. But what is good is the child treatment costs, because of our strong prevention of mother-to-child transmission program, that at least from 0 to 14, we're doing well. That bill is going down. The gap starts at Namsile's study, that it's the adolescent, and then that are pushing into the PLHIV population. Thank you. Next slide. And then now we know that it's showing me that feasibility is weak. But of course, we've taken 92%, and already there are no signs, but the threat is there. And then now it was to estimate the extent to which PLHIV can contribute, because it is my disease. And this one is primary data collection through 25 key informants, which are in the ages 19 to 56. And from those informants, I purposefully mixed them to have more of those that would be affected, the PLHIV themselves, and another group that would be those that would have insight into the broad fiscal and health policies vis-a-vis the HIV commitment to keep PLHIV on lifelong treatment. So that's the Ministries of Health and the Ministry of Finance, because if the Ministry of Finance says, forget it, we are sorted, do not worry about my macroeconomic indicators, that's a good thing. At at least they would have been aware and they would have a plan, and just to sensitize them on what plans do they have should this risk occur. And then the function, I was also chasing the institutional function, one of the healthcare providers themselves. I've got some doctors in private sector, some nurses in the public sector, and also the healthcare insurance, and also the development partners themselves. So now this was purposeful to get this mix of all of them, because on my head, for the PLHIV, humans would rather not spend than spend. So I would expect, I was preempting a resistance to taking up a bill, and also looking at their other commitments, but also to get a balanced view. That was why I included all of those. Thank you. Next slide. And some of the findings, the data collection is still ongoing. So, but some of the headlines that I'm getting is that the consciousness of the threat, all the thing are showing that everybody agrees that HIV financing is going to be the new challenge for the response. And the issue of HIV and ARVs drugs is very much critical, as evidenced by the advocacy by PLHIV at the World AIDS events, saying we are worried about the loss of Panados. Next week it will be ARVs. And that's one of some verbatim from some of the informants. If other drugs are out, chances are it can affect the ARVs after some time. And the consciousness of the threat discussions also is that there's also the general belief that this is a right, it's a human right. And partially that is true, because the voices coming out is that, but it is my government that said I must come in quickly and get free ARVs. But it is my government that said I must take ARVs before I am even ill. So they can never renege on 20% of the population. And also the economics of it, of some saying that would government is a macroeconomic be fine with 20% of the population affected, because some of that, the labor productivity issues would also be impacted by just disappointing 200,000 of Emaswati. And then on the willingness to pay aspect, I'm getting a feel that one, I'm overextended as a PLHIV. I'm already self-financing the lab costs. I spoke about the fragility of the health system. So some of them are already self-financing the cost for the 6 months treatment. And some of them are saying, I'm in a social class where if in a social class where I can afford it, I know every month I have this project for my care. So the ones self-financing are already saying that this was what I preempted, and that's why I've insured myself for this one. And the growing view is that if I was working, I would save myself from the spending uncertainty. So then this fits in well with other scholars, the Moabis in Nigeria, who found the willingness to pay for ARVs as well. And they found that the determinants for it were, of course, the income level and the employment status. So again, even though it's qualitative, I'm getting a feeling on it, but generally there's willingness, but inability, but it will come in stronger after I've concluded all my interviews. Next slide, please. In terms of the ability to pay, it's that most of us are not in formal employment. With the recession, that's currently economic recession, we just clearly would not cope with an added bill. But this is still anecdotal. I am still going to probe it with the current health expenditures using our national health accounts, that because scholars had said that the critical level is catastrophic health expenditures that exceed 40% or something. So I'm still going to explore that one. But in terms of the qualitative findings, that is what I am getting on affordability. And also the discussions coming out is that there's a feeling that there's some efficiencies that can be done within the HIV treatment program and the response in general. And some of it would be the stock procurement and management. What we have in Eswatini coming out of COVID was that we then came out with a brilliant idea when there were restrictions of movement. We said PLHIV can get a multi-month drug dispensement. So most of them are sitting with 6 months stock. And that's good because there's the 6 months leeway for government for any eventuality. But some are saying this stock is probably not moving because the frequency to the clinics was ensuring that I am taking all my pills, but now I have 6 months to play around. But it's still it's anecdotal and self-reported. And also the general feeling is that as long as we do not invest in HIV prevention and STI control in Eswatini, then we're just running a bad system, because without the prevention closing, that's there. So even they were speaking about treatment, but I say start with prevention. And in terms of some of the domestic co-financing option, it's the resounding voice is that the safest bet is the private health insurance, even though government is still studying the universal health care. But the comfort is that they are saying, most respondents are saying, take the bill that you have in your public budget, pay some of it to the private health insurers, and then should any risk occur, then we can easily be picked up with that. And I thought that was really innovative, because I know government would not necessarily want to take the entire chunk, but that's something that, so I am finding, I'm not happy with the willingness, but I am finding something, at least there's some discussion on the solution. Thank you. Next slide. So the savings aspects, the savings cannot be generated without willingness and ability. So this one is still work in progress. Next slide. And then the discussions, I think, that are coming out of my study is that as the world drives universal treatment, the discussion must never go without the long-term financing of HIV, because was just get everybody on treatment. We know the donors are leaving. We know that the wars are going to take, if the wars break out more, then the donors will just follow, the money will go to the defense. And we're really sitting with a problem. And here was the world advising it to go universal treatment. So that discussion, I think, needs to be, you cannot discuss universal treatment without discussing where the money will come from. And then also definitely high burden countries like Eswatini, Southern Sub-Saharan Africa, they really need to review their domestic fiscal policies to safeguard the demands of treatment. At least it's echoing that this is a bill that will stay with us until the last PLHIV drops or a cure occurs. And we heard from the first presenter that the cure is still nowhere in sight. And then there are opportunities of the taming the costs of the drugs themselves, regional procurement, at least that's being studied. And definitely prevention, because we would then be only dealing with 200,000 who would follow through natural attrition. But as long as the prevention tab shows that that discussion from Namsile, it's a problem for my study. And then also the universal health insurance, the private partnership with the private sector to really take us up to backstop government. And then also, I think the most take-away message is that having achieved epidemic control, the discussion on PLHIV self-financing needs serious consideration and more research, because it is now honestly a manageable chronic illness. Thank you.
Thank you, Nokwas. So the floor is open for discussion. People should type questions. I'll be reading them. Yeah, there's network challenges, but I'll try to be on video. Now, the first question is from Bongani. It's simply asking if participants will have access to slides. Let me quickly answer it by saying you will have access to the recordings, I think, through the School of Doctoral Studies. So the first question
I
goes to
may
Melis.
answer this
Yes,
question
yes,
that
yes.
following
Continue, Olga.
this event, we will share with all registered applicants, attendees, the recording, which will be uploaded on YouTube. It will be available for all.
Thank you, Olga. So the first question goes to Melissa, says, what is being done to address issues around cultural beliefs as regards to use of condoms in Eswatini? Maybe we start from there. And Kamusira, yes.
Yes, can you come again? I didn't get the question.
Yes. In terms of cultural beliefs, how do we address the issue of condom use, as it seems to be against cultural beliefs in Eswatini? The question is coming from Melissa.
Okay. No, thank you so much for the question. So we do like educate. Okay, start my video. Okay, so we do educate young people in terms of the cultural beliefs regarding condom or any form of HIV prevention method. So it's not like it's not addressed, but the issue again here, like I indicated in the presentation, it's that it depends on the partner. So long as the partner knows that what I feel like at this point in time should go, then the young woman is just supposed to accept that. Actually, it then just grows with the woman, because even the parents themselves, if I'm a married woman, then my husband says this, I socialize my children to also do the same. So those are some of the things to say. Now it's just part of our culture, because of the parents, that's what they socialize their children, to believe, whatever cultures that they uphold, they socialize them in that regardless. So that is why then we would recommend that sexual education is just not supposed to be merely for young people, but also the parents, the communities are supposed to be educated so that they're able to support young people to take on some of these prevention methods. Thank you, and over.
So we can see there are challenges on Dr. Masebo's side. Yeah, Dr. Masebo? Dr. Masebo? Yes.
Yes, internet challenges. So there's a similar question again to Kamusire from Dr. Kamel. He says practical solutions seem to be a challenge to the population, and considering that the strategies are not working, including condom use and abstinence, what do we suggest to the population?
Okay. Of course, with effective education and availability of information to young people, it could work. So, because the issue here is that, are we giving them the correct information and using every platform where we access them to be able to tell them? Because the issue is that sometimes when they get information in one place, young people will want to validate it. The previous speakers have talked about even access to social media, internet, and so forth. They take information from one source, validate it, and they just did the conviction. So if all these platforms, we are able to make sure that we reinforce information, then it will help, because then they'll be convinced and they'll be able to take on those. And we should remember that people, like as a person, whether young or old, you just need to make sure that you believe in that intervention and the efficacy of it, just to make sure that you're able to apply it. Because otherwise, if you're not, you don't believe that it will work, then you're not going to take on that. So I think it's just making sure that we use every platform. We know that it may not be all young people, but they have access to internet and so forth. So even before they ask you, they would have searched even whether it's a parent or at school, wherever. So if we are able to make sure that at least there is a trusted place within the internet, especially for our programs, where we upload correct information and interact with young people, I think that could also assist in making sure that they can freely, during their time, interact with that information. Thank you.
Thank you. Let us move to Nokwas for now. There's a question from Gift. He says, how do we then sustain the gains of 95? And is giving examples from Malawi and Zambia. And considering that we have weak economies, like you have indicated, Nokwas in Eswatini, and yet we depend on donors, and yet there is donor fatigue. And therefore, our programs are donor funded. But then how do we sustain the gains in the absence of donors? I think it's trying to summarize your presentation.
Yes, thank you for that question. Indeed, that is what the study seeks to do as well, to generate that discussion for high burdened countries, should be that we're now discussing. Not whether the pill is working, it's definitely working, but how are we going to maintain it? So it's going to be those innovative sources, whether PLHIV take a part on own illness. It's going to be the procurement issues, taming the cost of the drug, and of course, like we said, a pool, safeguarded pools, because countries like Zimbabwe are lucky because they have that HIV fund. Others have an HIV fund that protects it out of the risks of the fiscal budget. And for us in Eswatini, we do not have it. So those countries will be cushioned. So there's some options, but it's for that, to conscientize us and get the discussion going. Thank you, over.
Thank you, Nokwas. So there's another question from
Dr.
the Director General.
Masebo, sorry for interrupting you. I can see that Dr. Kayumba has a question.
Oh, let me ask.
Hello.
You raised your hand.
Hello. So mine is not a question, but I just wanted to comment on the question that has been raised about sustaining the gains. So you gave an example of Malawi and Zambia. I think that is a big question, which we are actually trying to answer even in Malawi. As we said, we have already reached 95, but how are we sustaining that? So you may be aware that countries in Africa, we are developing sustainability, HIV sustainability plan, roadmap, which we are actually teasing out, finding solutions to the questions that you have raised. And in most countries, by 1st December, they had already come up with the key outcomes or areas that they are thinking that they should focus on. And after that is when now we are going into the details of how really we are going to do or to achieve the outcomes, the key outcomes that we have actually come up with. So it's not a simple question to respond. Of course, we may have several thinking to say A, B, C, D, but it needs thorough thinking of how really we are going to do it. And the HIV sustainability roadmap is one of the tools that will really help us in responding to that as we go towards 2030. Thank you.
Thank you. So again, I think to Nokwas, there's a question saying from Innocent that you are proposing that people should be sharing the cost, and yet the majority of population receiving treatment are the elders and are retiring. Where would they be able to get the finances to support their treatment?
Yes, thank you. That's also a good question. And I think for Eswatini, and I thank you for that because the model gave me the population split. I think for Eswatini, if you look at the population diagram, it's really within the reproductive ages, meaning the employment population is there. But I do take your point. We have a few, for Eswatini, we have a few people, PLHIV over even 70. So for us, that one. But what I think I also take from that is the income. The poverty dynamic and HIV. So you would expect what we were hearing in the other presentation, transactional sex, and that tells us that there's the money power play. And if that person gets HIV, they still don't have the money. So it's a valid question. It's a valid question. But the discussion has to be had. We may not do it for, this is not, it's just to respond. We may not do it perhaps for this one because it's against human rights to remove a benefit from somebody that was previously benefit. So definitely this cohort can next, but the next cohorts the discussion can start introducing those user fees. So it can be sequential because people living with kidney dialysis have equal rights as PLHIV. But that's not fair because it's now showing perhaps it would be a researcher's bias, but I'm just responding to your question. Thank you, Over.
Thank you. There's a question, I think, from the Director General of National AIDS Commission in Zambia to Kamisile, saying previously there was what we call extended family cohesion, whereby the aunties, the uncles could provide some wisdom, some counseling to the young ones. But there is some sort of breakdown in such arrangements. And therefore was trying to ask, saying, how does now we incorporate them in the sexuality education platform? Thank you.
Okay, thank you so much. Definitely, that's a good one. We start incorporating them by making sure that they are part of this adaptations of the curriculums that we are using. Because also the families, like most children, like in Eswatini, it's either they are single parents or they don't have parents at all. So definitely then the grandparents and so forth are even no longer there. And even if they are there, they stay far from each other. So that safety net that we used to have previously, it's no longer there. So now what we have to do is to make sure that the structures that are there now, they should take charge. And also, why am I saying that? It's because back then you would teach those children at a certain stage. But now there's issues of contraceptions, there's issues of early sexual debut. So how do you then, make sure that you are protecting these young children? That is why then in schools and also in communities where there are other platforms, we want to take advantage of those because now there's a lot of advancement in terms of our sexual and health, reproductive health, in terms of the commodities that are available. So because we are having those, and young people also now delay marriages. Back then, also the marriages, you get to a certain stage and then it will be a recommendation that now the young person is ready, they can, give away a hand for marriage. So those are some of the things to say. Now young people are even delaying marriage more, and some of them they actually opt out of marriage. So how do you balance that? So because some of them are not going to even get married, so you want to make sure that at least even if they stay on without being married, they also get the information and they are able to protect themselves from HIV. Thank you, Nova.
Yeah, there are so many questions, but considering time, I don't know how we proceed. But maybe I ask you again, Kamusira, before we go to Nokwas. There's the issue of gender-based violence, and the person has given an example from Nigeria. He says, how then do we address gender-based violence? Because it might be a perpetuator in terms of transmission of HIV.
Okay, yes, definitely gender-based violence. Actually, gender-based violence is an outcome. That's what we see because of the gender norms and social cultural norms that are promoting how the two genders are supposed to interact with each other in a relationship. So once we understand that, because I know that people sometimes they say once we've trained people on gender norm, on gender-based violence, then they're supposed to understand and be able to be equipped to stand against it, which doesn't necessarily is the case. You need to make sure that there's a specific content that addresses to say what are these gender norms and how do they affect an individual? How do they predispose one to HIV, and then how can one make sure that at least they protect themselves from those harmful gender norms that are identified. So it's always good to understand when you're doing this curriculum to say, we're not talking about GBV and gender norms, which ones are they? Have an assessment, and then once you identify them, you have specific interventions that would address each and every issue that has been identified by the assessment. And that is the one way where we can empower young people. And then once it's there in the content, let's make sure we educate them. And then because we also have these traditional parents and so forth that are against that education, that is why then we need to make sure that the stakeholders are part of the discussion in terms of defining the content. But other scholars would say once we involve them, then they water down the content. So how do we then balance the two? So that is where then policymakers come into the whole frame to say, we are seeing, because like in every country, there's a reported high rate of GBV, and most of them it's it's IPV, which is intimate partner violence. So what is the issue? So you can already tell that there's something in relationships. So then once you understand, let's address it. Let's have everyone coming together and defining the content and making sure that young people, as they grow, they are equipped and they are able to stand for their rights. Thank you.
Thank you. There's a question to Nokwas, and it is from Musa in Nigeria. He's saying you are proposing that Africans will stand alone and run away from the donors. But how possible would this be, considering the issues of corruption in Africa? How would African governments be able to manage the funds and not have people stealing the political corruption and other things? Thank you.
Thank you for that question. Indeed, that's for serious consideration. And I think the first bit in responding to is it a suggestion to divert from international? No, it is clearly not. It is a reality that if you can look at most NASA's, most HIV spending assessment, they are all showing the reduction of the international sources of financing. So it has already occurred that's a foregone conclusion that the international financing is on its way out. It's just to prepare Africa. So do we wait until the last donor says, I have a war in Ukraine, and then we start coming together and saying, oh my God, we have 200,000 that we put on a pill. So it's not really saying that. In fact, most studies, when I was researching, we're coming out with clear directives that Africa cannot survive without donors. Africa would not survive. But how far do we do? The donors are going. What do we do? And of course, the corruption issues for Africa, that one, we definitely need God in that one. Thank you.
Thank you. Maybe the last one to Kamusire. There is a question as regards to stigma discrimination, saying how do we address these in the communities so that we are able to have the majority getting tested, as a result being able to access treatment? How do we address the root causes of stigma discrimination issues?
Okay, thank you so much. It's just interesting that over 30 years, and is even more than 30 years of HIV, we're still facing the issue of stigma and discrimination. And I think it's because, most of the time now we shift from HIV prevention, education, sensitization and everything, and move towards treatment. And yet, for us to be able, to curb the entire stigma, issues of new infections, prevention is very vital, especially for the, young population. So I think for me, what we would want to do is to make sure that at least we continue to go back to our routine HIV prevention methods of sensitizing not just the target beneficiaries for our programs and so forth, but for everyone, because you want to create an enabling environment where this HIV positive person exists, so that the systems and structures are supportive of that. So because the issue now is that if we're only sensitizing those who are affected, then we are just talking amongst ourselves. So we need to make sure that there's widespread HIV prevention education, and also because now we have also young people that are born with were born with HIV. Some of them are already of age, they are in relationships and so forth. So how do I then disclose my status? Because for me, what I found in the study is that some of them were saying they are not even able to disclose to their status because of the stigma that if I disclose to my partner, then they're going to leave me. And because of fear of rejection, then they just keep quiet and infect the partner. Then it also leads to more further, GPV, because now once I know that I took it from you, then it's a problem. So what do we do? I think it's just sensitizing, the public and everyone to say, now we are living with HIV, and HIV is not actually death, because back then, before there was treatment, where they said, okay, now I've got HIV, so I'm only left with a couple of years and then I'll die. But now with all this prevention, methods, you can be in a discontent couple and use PrEP, to prevent. And also, again, condoms are the best prevention method, because for whatever pregnancy that young people always are afraid of, they can use condoms. And the earlier we introduce that to them, they'll be able then to take up condoms, because for them it will be just a norm to say, when I have a sexual activity, I use condoms. Thank you.
Thank you. We stop here. Again, thank you so much. Our invited guests, our VCs, the Dean from School of Doctoral Studies, our presenters, and all the participants. Let me pass back to Dr. Lidre, our Vice Chancellor. Thank you indeed. Thank you.
Thank you very much to the speakers, and thank you for the discussants and the questions that came in. We're running very short on time. And we do have to finish the Zoom meeting by 5 o'clock. So if I could just ask Dr. Muskotwane to say a few words, and then Emily Kayimba, and then I will just say a few words just to finish off. Dr. Muskotwane, could you just provide us with a few comments? Thank you.
Right. Thank you very much. Very interesting discussions. And once again, I thank you very much for inviting me to join this discussion. Maybe just to comment to say that we have our work cut out for us. I know there's a lot of discussion going around for us saying that we are approaching epidemic control, and whenever I hear that, I sort of cringe a little, because yes, in terms of the UNAIDS global targets for HIV that were set, the 95, 95, 95, we may be doing well. But if I can give the example of Zambia, for example, the 95, 95, 95 were 96, 97, and 98. So for the first 96, which is the people living with HIV that know their status, is 96%. That 4% that is we are still to find translates to 42,000 people. The next 95 were at 97. The 3% that are not put on ART translates to about 30,000 people, 32,000 people, somewhere there. And for viral load suppression, we are 98, 99 right now. Those that are not virally suppressed, are approaching 20,000. With the new infections that we had last year, we had about 28,000 infections last year. We are talking about a cohort or a foci of infection of 120,000 people around the country. And that is if estimates are to be believed. So we're still very far from epidemic control. A lot needs to be done. I appreciate the discussion over the sustainability, because for sure our governments seriously really need to take the bull by its horn currently. Except that facing reality, for example, again, I come back to my country, Zambia. Last year, we had a major drought that affected over 116 districts, affected 109 districts. Severe drought to the extent that we are talking about food security around the country. And so you can see the priorities that the government has. So to speak about sustainability, and for sure for them to be able to put pen to paper for something that is meaningful is a little bit difficult right now, especially that there's still a lot of it's still opaque. It's not, the discussion is not so transparent in that we are not even aware of the funding reductions that will follow until 2030, for example. So I think that is still a lot of work in progress. And for Zambia, I might add also that we have a serious debt restructuring here of is it 16 or 17 billion dollars that has been successfully restructured, but I mean that money still has to be paid back. Just to sort of explain the fiscal space that Zambia is in, and I suppose other African countries, and so the issue of sustaining these programs really becomes even much more important. But anyway, just to reflect on the themes that are overarching that have emerged, that I've heard, we've got the power of integration, combining technologies, education, policy solutions to yield transformative outcomes in the HIV response. The second one is the centrality of human rights, upholding dignity, privacy, equity of people living with HIV, which must be guided by all interventions. The need for inclusive collaboration cannot be overemphasized. Success depends on partnerships between the governments, academia, civil society, and the communities. I think those are my concluding remarks. Thank you very much.
Well, thank you very much for those comments, and pass on to Emily for some final thoughts.
Okay, thank you so much. I don't have much to say. I just want to say a thank you for inviting me and the even National AIDS Commission to attend this meeting. And let me also thank all participants and for the meaningful contributions, and especially the panelists and the speakers for their expertise. Thank you so much. We have learned a lot, and I've learned a lot myself. And from the presentations, you can see that there is really a lot that we are supposed to do. We still have a long way to go as we are going closer to
I think we've lost Emily.
Yes,
But I think just to Olga, do we have a few minutes after 5, or are we going to be cut off at 5 sharp?
Yes, we can extend for about 10 minutes now.
Okay,
yeah.
Right. No, so I don't think we need to extend for 10 minutes, but I'd just like to thank our guests, Kevi and Emily. It's very important that as part of the academic discussion, we have your practical knowledge and experience feeding into that and setting the groundwork. And
hello.
Oh, yes, Emily, do you have some final?
Yes, I'm sorry. I will start. My internet was cut. So what I was actually saying is that looking at what we have actually presented and what I even said during my opening remarks, we still have some challenges, and especially Malawi in the areas of pediatrics, the key populations, and the adolescent girls, and even adolescent boys and young men. And these are especially in the colleges. And we are seeing that I think working with the even Unicap can help us as much as we are working also with the other university institutions. It can help us really to dig deeper and find solutions of some other challenges that we are actually facing. You are welcome as the to civil society, which through Manaso, that we should work together, especially in the areas of research, because this is the area that we are actually want the institutions of higher learning like yourself to help us, so that when we are advocates, when we are going out to advocate for several issues pertaining to HIV, we have actually evidence that we can win whatever we are actually presenting to the stakeholders that we do. And this has also come at the right time, this meeting, as we are developing the strategic, the sustainability roadmaps. So with all this, we rely on you to help and feed into the roadmaps that the countries and even Malawi particularly, because I'm from Malawi, on how we can even go about and think that we are actually sustaining the gains and working on the other areas that we are not doing fine. So thank you so much, and we are looking forward really for more engagement. Thank you.
Thank you very much. Thank you. So as I was saying, I'd like to thank very much our guests, Kebi Musukutwani and Emily Kayimba. Your presence has really enriched the discussion. I'd like to also thank Dr. Chela for a very enlightening talk on the interface of HIV and AIDS and AI and the ethical issues associated with that. Our chairs, Wilfred Maceo and Wila Mwaba also. And last but not least, our two doctoral students who gave excellent presentations. And I'm sure that both of those pieces of research can feed in locally to Eswatini's policy discussions and directions. And I think you've given food for thought to us in Malawi and Zambia, also around some of those issues, the sexuality issues that are often not openly discussed, but are particularly important to the disease control, and ultimately also the financial aspects, which really feed into the whole element of sustainability that was also stressed by Dr. Musukutwani. I've just, for the National AIDS Council of Zambia and National AIDS Commission of Malawi, and also Manamo, I think it's very important that we do engage with you, because the most important part of a doctoral dissertation or a master's dissertation is the initial question. And I think we have to be working together with you to define the questions that we'll be asking through the research. And it may be that, you know, we can help you address specific issues and questions that you have, and we can interface in that way and collectively increase the value of the research we do by improving and enhancing its relevance. The other element I'd just like to mention, I think from this meeting, it shows the value of exchanging information between countries, Zambia, Eswatini, Malawi. We all have similarities. If we can combine our knowledge and information, that is likely to be to the benefit of us all. So with those few remarks, I'd like to thank everybody once again for attending. There have been well over 100 participants in this meeting. From as far apart as Indonesia, we had some questions. So thank you very much. And I pass back to Olga for final logistical comments. Thank you once again. Thank you.
Thank you very much, Dr. Ridley. Thank you for leading us through this event and for encouraging all for communicating these important points. I should say that we had more than 1,500 registered attendees who will receive our recording of this event today. So we are reaching all of attendees globally, not only from the 3 countries discussed, but globally of the world. Thank you all for attending today. I would like to thank our presenters and guests, and we are looking forward for new events. Thank you and have a nice day.